So I'd like now to introduce the next keynote speaker for the conference, Associate Professor Kamalini Lokuge. Kamalini is a public health physician and medical epidemiologist who leads the Humanitarian Health Research Initiative of the National Centre for Epidemiology and Population Health, NCEP, at the Australian National University. For over 25 years, Kamalini has worked with Médecins Sans Frontières, the World Health Organization, and the International Committee of the Red Cross, tracing and halting outbreaks of high-risk pathogens such as Ebola, Lassa fever, and avian influenza, and other humanitarian emergencies. She developed what are now globally adopted approaches for upstream and downstream contact tracing, looking not just at who has become infected from a particular case, but also how that case itself became infected. During Melbourne's second wave in mid-2020, among the migrant and aged care communities in particular, the Victorian Department of Health and Human Services brought Kamalini to Lonsdale Street for 6 weeks to successfully guide them through. And Kamalini provided similar guidance to several other states and territories, and as a member of Australia's National COVID-19 Health and Research Advisory Committee. The Western Australian government sought her expertise to successfully defend their border closure policy against Clive Palmer in the federal and high courts. And these were her day jobs. By night, I know that she was on the phone, providing much valued advice to her extensive network of colleagues at World Health Organization in West Africa and elsewhere around the globe. Kamalini and her team also work on non-infectious diseases, particularly vulnerable populations affected by marginalisation, poverty and conflict. Common to all their operational research is that it is done in partnership with communities and service providers, aiming to understand and support communities to engage effectively in improving their own health and to inform effective health service delivery and prevention. Kamalini frequently says that to treat people and prevent them from getting sick in the first place, she needs to understand them, the context of their lives and that of their families and communities. Then, by integrating lessons learned in the field with traditional research activities, they create an evidence base on how to achieve better outcomes for those living in the most challenging circumstances. Kamalini has been honoured with the Medal of the Order of Australia in 2010, the Humanitarian Overseas Medal in 2018, the Royal Australasian College of Physicians International Medal in 2020, the ANU Vice-Chancellor's Award for Impact and Engagement in 2020, and most recently, the ANU 2021 Alumnus of the Year Award, in which, as a tribute to her humble service, she was dubbed Australia's Pandemic Whisperer. Kamalini, over to you.
Thank you, Russell, for that introduction. I'll just start sharing my screen. Do you have the right slide view? Thank you, Russell, as I said, for that introduction, and to the Academy for the invitation to speak today. It's really a privilege and an honour. I'd also like to acknowledge the Ngunnawal and the Ngambri people on whose lands I am presenting today. I pay my respects to the elders past, present and emerging, and I also acknowledge the traditional lands of other participants in this conference today. In my presentation, I want to address these points, which to me have been the most important lessons of COVID-19. First, that the public health measures underpinning successful control were informed by high-risk pathogen-related expertise and operational research, much of which was conducted in and came from developing and low-resource countries. The second, that those setting the settings that experience high case numbers and health and social impact, despite very well-resourced health systems. This was in part contributed to by flawed evidence informing policy. And thirdly, to me, what was the most critical, that transmission was driven by structural disadvantage and that we lacked the expertise in community-led response to address that. And I want to conclude with some thoughts on a way forward that builds on these lessons, including what it means for our system of evidence generation. My experience responding, as Russell said, to high-risk pathogen outbreaks of diseases like Ebola and Lassa in low-resource complex emergencies was key to informing the work that I've done in COVID control in Australia over the past year and a half. That past work taught me that while health system limitations are a challenge, in those countries that face significant constraints on their capacity for curative care, what that's meant is that for all levels of policy and decision making, there's a really clear understanding of how critical, how essential effective prevention is. And I think that's not an understanding that is as at the forefront in well-resourced, developed healthcare systems. The other was the fundamental importance of community engagement, and that without that, no aspect of response succeeds. And I think those two things underlie every response that I've engaged in internationally. This slide outlines some of the key aspects of Australia's public health response that I think was informed by and often originated from international experience in those settings. For example, initially in many developed countries, including Australia, surveillance for COVID-19 was focused on, and testing was focused on international arrivals or on severe hospitalised respiratory disease. And the shift to more community-based testing of those with milder symptomatic disease was informed by work we did demonstrating that if the goal was to identify transmission, neither of those other strategies, but instead one focused on identifying individual trends of transmission in the community and following them upstream and downstream was critical. Most contact tracing up until the arrival of a pandemic disease such as COVID was based on point source foodborne outbreaks or single disease introductions. And because of that, there was not a strong focus on how critical transmission chain mapping was, and in particular understanding acquisition or upstream contact tracing. And subsequently, another key aspect as the outbreak progressed and as variants with high transmissibility emerged, another key aspect was secondary contact tracing. And just as effective surveillance case and contact tracing were critical to achieving and maintaining control, in the early stages of the pandemic in Australia, our public health capacity to implement those measures was very limited. And it was the rapid and stringent lockdowns and border closures that we implemented that bought us time to build this public health capacity. All of those key strategies that I outlined in the previous slide were based on expertise and operational research in high-risk pathogen control, as I said, much of that in developing countries. And I want to illustrate why I say this using the example of the response to the Ebola outbreak in West Africa in 2014 and how the practical understanding of that response informed our COVID response. So as I mentioned before, key to the epidemiological control, understanding and control of Ebola is transmission chain mapping of the individual relationships between cases. And this is a diagram of the first transmission map I did after I arrived in Guinea at the start of the West African outbreak. Each horizontal line represents the infectious period of a single case. The key to control of Ebola is to identify the links between each individual in those transmission chains, as that allows identification and management of all cases and contacts. And that's achieved first by detecting at least one case in a particular chain through community-based surveillance, testing of those who meet the surveillance case definition, and then linking all members of that chain through contact tracing upstream to identify acquisition, and as I said, downstream to identify exposures initiated during the infectious period. Obtaining the information that goes into transmission mapping is based on what we all know now, speaking with patients, their families and communities. And although we tend to focus on the technical aspects of that, how many days were they, when was their disease onset, those sorts of things. In my experience doing this work, the most important part of any interaction with patients, their families or community is that of building trust. And often that's something we forget, we neglect, or we don't understand in terms of how all-encompassing what we do is in building or in undermining that trust. An example is this old blue pickup. So although others in the outbreak team were using white Land Cruisers in Guinea, it was clear very early on, so within the first week of the cases being reported, that the community had already associated white Land Cruisers with the Ebola response. And a visit by a Land Cruiser stigmatized you as an Ebola household. And as a result, any visits by people in white Land Cruisers were met with anger and resistance. So instead, me and my outbreak investigation team, to protect the community from stigma, to support a relationship of trust, used this old blue pickup. During COVID, I've had reports from community members, people who've been visited for home testing, for example, that being visited by a vehicle marked with the health department logo and with people who got out of the car in full PPE, they found very distressing because it stigmatized them. It signaled to their neighbors that they were either a case or a contact. And I think those are things that were very clear to us in past outbreaks that we've had to relearn during COVID. Another critical aspect of building trust is embedding with those who were providing care and treatment and who were trusted medical practitioners prior to the outbreak, rather than those perceived as conducting public health surveillance. So that's a reason why in most high-risk pathogen outbreaks, I work as a medical epidemiologist or outbreak lead with Médecins Sans Frontières, or the organisation that's providing patients care, rather than organisations such as the World Health Organization, which are often more perceived as conducting surveillance and investigation. I think this is an opportunity that hasn't been utilised in Australia during the response to COVID. In most locations and jurisdictions, it's usually public health departments doing contact tracing, calling people, investigating cases. It's not those who usually provide healthcare to communities. And I think by separating public health measures such as contact tracing from healthcare in this way, what we lose is the opportunity to draw on the trust people have for their long-term care providers. And this is particularly important in my experience in communities that are affected by structural disadvantage and have less trust in health authorities or authorities in general. And those have been the same communities that have been most at risk and affected by COVID. And I think we missed the opportunity to engage trusted providers in our public health response. So Sierra Leone was the most affected country in the 2004 Ebola virus disease outbreak. And this is the epidemic curve of the outbreak in Kailahun district. Kailahun is the region of Sierra Leone that borders the part of Guinea where the outbreak started. And it was the first district in Sierra Leone to report cases. As you can see, the control of the outbreak and sort of the reduction in transmission occurred once the response capacity met the scale of transmission across all areas of response, not just bed capacity, but in terms of surveillance officers, contact tracing staff, patient transport, safe burial, the numbers of burial team members, and when measures to limit transmission like school closures and community and border restrictions have been implemented. This past experience controlling diseases like Ebola informed our work on COVID in Australia. The paper on the left, published in April last year, outlined a surveillance and outbreak response strategy that, as I mentioned, was based on community testing of respiratory illness and on contact tracing approaches I learnt in Ebola. And this informed key documents such as the Australian National Surveillance Plan. And the concepts and terminology we developed, as Russell said, upstream, downstream contact tracing, are now embedded in our response. And subsequently, another strategy we implemented in Australia was secondary contact tracing. This was critical to getting ahead of transmission as the virus increased in transmissibility. And it's now part of the Australian national guidelines, but was first reported, and our policies grew from documents we had read around the strategies adopted by public health departments in countries like Vietnam. I'll end this section briefly by discussing social and mobility restrictions. These have always been part of the control of infectious diseases, particularly those high-risk pathogens that don't have specific treatments and preventive interventions. And as I previously described, they were part of the response during the Ebola virus outbreak in West Africa. They were implemented early throughout Kowloon district, as I demonstrated in that epidemic curve. And they've always also been a key part of control in other past global pandemics, and were essential to achieving control in Wuhan in China, where the outbreak first emerged. However, there was significant resistance in developed countries to these measures, based on, with as far as I could see, no evidence, the perception that Western democracies would not tolerate such measures. Subsequently, as we know, that perception has been proven wrong in places such as Australia and New Zealand. However, many policymakers and experts did make statements such as this in Australia early on. And Australia only closed its international borders in late March 2020. And by that time, disease was well established in the community. We were fortunate that we had senior experienced public health advisors in state health departments that recognised the need for such social and mobility restrictions. And it was those lockdowns that were then imposed that allowed us to control the transmission that was already there and gave us time to build our public health response systems capacity to an adequate level. Now I want to address the issue which to me has been the most important, but equally the most overlooked, and which I think is the most critical to address if we're to improve our response to future pandemics, and that's that of structural disadvantage. This has been integral to infectious disease transmission throughout history, and addressing disadvantage through measures that improve living conditions was the foundation of modern public health. But we seem to forget this with every new outbreak, and the same happened with COVID. What underpins the successful implementation of any public health control measure is the social contract between government, between authority and the community. Long-term, high-quality universal health care through Medicare, the PBS, and extensive income support when the pandemic started meant that most Australians are willing to and were provided the means with which to comply with these measures. However, that wasn't the case. That social contract didn't exist between government and the most structurally disadvantaged groups. This paper is from a working group I chaired for the National COVID Health and Research Advisory Committee in May last year, which emphasised the need for community-led response, particularly for those affected by structural disadvantage and therefore less connected and engaged in mainstream health services. The subsequent resurgence of COVID transmission in New South Wales and Victoria, amongst other places, reflected this risk, and it's been a consistent part of COVID outbreaks in every setting globally. The map on the left is of relative socioeconomic deprivation in Melbourne, Australia's most affected city, and the map on the right is of COVID case density. As these two maps demonstrate, the most affected areas within Melbourne are also those with the highest levels of structural disadvantage. And if you do the equivalent maps for Sydney, they tell the same story. And I'm sure if you do this same thing in any city globally, it will be the same. What we've seen again and again in the outbreaks in Australia and in every setting globally is that COVID finds its way to those disadvantaged by insecure essential work, crowded and poor housing, language and economic barriers to seeking healthcare, mental and physical disease that puts them at higher risk of acquisition of severe disease, and past experience of trauma and marginalisation that's engendered mistrust in authorities. And again, our work in outbreaks in low-income settings guides us on how to address this, and that's through partnership with community, through community-led response. When I first spoke of this in Australia in relation to COVID, I think there was limited understanding in general of what this looked like operationally, what community-led response looked like. Often it was thought of as translation of educational materials into different languages and not a lot more beyond that. But community engagement, in my experience, requires more expertise than training than any other area of outbreak response, whether that's surveillance and contact tracing or vaccines development and delivery. This picture is of the outbreak response team I worked with in Guinea. Circled is Dr. Julien Nanoko, a Cameroonian medical anthropologist whom I've worked with on Ebola outbreaks several times. Julien was able to sit with me and with families affected by Ebola and find a way to bring together what I wanted to achieve in terms of public health control and public health interventions with what they needed to achieve in terms of care of their sick and their dead. It was fundamental, that expertise was fundamental to control. But during my work in COVID, I've not been able to identify similar positions in health departments in Australia. Where I have seen this expertise is in those who work in long-term partnership with community, in particular in the Indigenous health sector. We're now seeing community-led response in the rollout of targeted vaccine programs in some affected communities, but this has only occurred once transmission has reached a point where governments and authorities knew they had to try something different. I think we missed the most important opportunity we had, which was to embed community-led response in our response from the beginning, and as such, I think we missed the opportunity to control COVID, particularly before it impacted those in our community that are the most structurally disadvantaged. So where nations have succeeded globally, they've taken the approaches outlined in my previous slides, and they did so early based on past experience with pandemic disease and on an understanding of the foundations of public health measures for control. However, many developed nations did not apply this empirical evidence. Instead, they relied on evidence, for example, mathematical models that did not include fundamental aspects of control, such as community-based case detection or contact tracing. This led to assumptions that disease could only be limited through lockdowns, and it led to concepts such as herd immunity through infection, something that has never occurred as far as I'm aware for any infectious disease. Those wealthy, developed settings have suffered disproportionately despite being considered world leaders in pandemic response prior to COVID. And I think those who put forward such poorly evidenced policies need to reconsider the reasons for why they didn't look at the empirical data that already existed. Early on, Australia too seemed like it was going to be guided by such evidence, but we were fortunate again, as I said previously, that we had people with practical public health disease control experience in health departments who knew otherwise. I want to end now with a brief discussion of what I think those learnings from COVID mean for the way we value and generate evidence. The most important, again, as I've said many times in this presentation, is the evidence we need to address structural disadvantage. It can only be addressed by improving the determinants of health, many of which are outside the health system. An example is insecure work, which has been a clear risk factor in the outbreak in Australia and in every other setting. It also intersects with multiple other risk factors for COVID acquisition and for COVID severe disease. Earlier this year, a bill was introduced to the Australian Parliament to make work even less secure. My colleagues and I made a submission on how this would increase the risk of COVID outbreaks and undermine our capacity to control COVID and future pandemics. As ours was one of I think the only submission related to public health risk. And why did we as public health experts put a submission into a workforce relations inquiry? Modern day public health, as I said, is attributed to have begun from these sorts of interventions. From Dr. John Snow, who was investigating a cholera outbreak in London in the 1850s. He traced it back to a contaminated water pump, and by closing the water pump, he ended the outbreak. To my colleagues and I, a submission to the Fair Work Amendment inquiry was just as much public health as John Snow removing the handle to the Broad Street pump. The other critical aspect is what research we choose to fund. If we look at Australia's investments in evidence generation around COVID-19, the vast majority has gone to developing new technologies, to clinical trials and to modelling. Little has gone into better empirical understanding of core public health response measures, such as surveillance and contact tracing, and less, if any, to understanding how to partner, how to engage, and how to support community-led response. If we consider which of these investments best serve the Australian public, it's clear that we need a better balance between technology, technical innovation, and empirical public health research. Vaccines and other technologies and tools are critical. They are essential to effective response, but they are not enough, and in my experience, usually not the hardest part of achieving successful control. Even once we have these technologies, getting them to whom and where they are needed most is often far more challenging. And it's those aspects that we usually neglect. I think this article from The Onion during the Ebola outbreak in West Africa sums this up effectively. It's titled, "Experts Say Ebola Vaccine by 50 White People Away." In fact, it was 12 white people, I think. Much more of a challenge to global COVID vaccine access and the innovation needed to develop them has been the barriers to scaling up production of vaccines, such as intellectual, patent and property protections. Again, we knew this from many years ago and have done little to address it. And the lack now of vaccines in many developing countries has resulted in the fact that we now face the ongoing risk, all of us, not just those countries, of new variants. Similarly, delivery systems for vaccines get much less focus than the vaccines themselves, but are just as critical. Ebola vaccines, such as the Pfizer COVID mRNA vaccine, require ultra-low temperature cold chain, so -70 degrees. Due to new technologies, such as this Arctic ultra-low temperature vaccine carrier, Ebola vaccines that required those ultra-low temperature cold chain systems were delivered to hundreds of thousands of people in remote parts of Central and Sub-Saharan Africa. But this vaccine carrier technology was not funded through government research institutions or schemes, but by philanthropic investments in patent-free technologies for developing countries. As a side note on an earlier point that I raised, related to where we do and don't look for evidence, the fact that these cold chain innovations delivered vaccines to remote areas of Africa several years before COVID appeared to have been overlooked in early discussions, which were suggesting that ultra-low cold chain was too challenging even for remote Australia. Given I speak today to an Academy of Research and Scientists, I would like to end with thoughts on what I think this all means for our current research system. First, I believe that we need to value evidence wherever and by whomever it is generated. In the same way we know to be aware of unconscious bias in decision-making in other areas of life, we need to be aware of it when considering evidence. To be aware that we may be at risk of disregarding the evidence we need to keep our communities safe, simply because it does not come from institutions and researchers that look similar to us. Second, we need to value and invest in practitioner-led research in other fields aside from clinical medicine. Why were my team and I in a position to support Australia in its COVID response? Because my institution has supported the work we do for over a decade. My job description includes at least 2 field-based humanitarian outbreaks or operational research activities per year, something no research funding body is likely to support given current research assessment processes. And my position is unlike many of my colleagues in health departments and other universities in Australia who, for example, were told during the West African Ebola outbreak that if they wanted to assist, they would need to take leave without pay. We need to shift our research system to one which values practitioner-led field-based operational research, including in settings experiencing far greater challenges than Australia is ever likely to. And finally, and most importantly, if we're to generate evidence on community-led response, we need systems that support emerging leaders from those communities that face structural disadvantage. We've started that process in Indigenous health research that is led by Indigenous researchers. We need to apply those same processes to other groups experiencing structural disadvantage if we are truly committed to research that will improve our response to COVID and to future pandemics. Thank you.